So yeah, thanks, Maria. Thanks for having me today. So my kind of educational background, I was trained as a clinical psychologist, which is not an abnormal path for folks here in the States anyway, to start out in clinical psychology and end up in implementation science. Lots of different fields, obviously melting pot, but yeah, that's relatively common. So I started doing dissemination implementation research as a postdoc oh wow, gonna definitely date myself, about 11 years ago when I started postdoc, and have really focused on implementation research methodology. So my actual substantive work and content area is predominantly focused on changing practices within primary care for kids in pediatric settings. But I also have a number of grants for adults, also in primary care. And then I collaborate on a lot of different implementation research projects in the fields of HIV, cancer prevention and survivorship, living kidney donors, atrial fibrillation, all sorts of different areas, cardiovascular health. So being a methodologist, I get to kind of put that hat on for a lot of the projects and get to learn a new content area. So it's kind of a never get bored situation. And I have been at the University of Utah for about 2 years, if that's in any way relevant. All right, let me make sure I'm gonna get slide deck. Okay, I will try to keep track of my time, obviously, and try to stay with the advertised schedule as much as I can. So I was asked to talk about implementation research designs and methods. I'm going to talk specifically today about testing implementation strategies, because that really is what gets us into experimental and quasi-experimental designs. So there's lots of other research designs that I will touch on really briefly today. Some of those are for like smaller ends, or maybe for purposes before formally testing implementation strategies, which we might kind of consider as part of implementation preparation studies. So I'll talk about those here in a minute as well. So our objectives today are to learn different types of research designs for testing implementation strategies. I'm also going to touch on hybrid effectiveness implementation approaches, which is sort of a special class or maybe a somewhat unique aspect of implementation research. And then I'm going to give a very brief introduction to the implementation research logic model, which is really more of a method or a tool to help researchers design, plan, execute, and then report on implementation research studies. So I hope it's going to be a little bit more of a teaser. There are other longer presentations on the IRLM that are actually available on our website, and just by Googling, actually, I've done it a number of times now, so people have posted it where it's searchable. So, I kind of want to just level set a little bit. I know you've been hearing about implementation research and the perspective of implementation scientists for the last couple of days, but just as it concerns, the testing of implementation strategies, I think that the crux of this is to understand that the delivery system is really what matters. It's not the only thing that matters, and you'll see in the hybrid designs in particular that we have often a dual focus and still care about the clinical effectiveness outcomes. But in implementation research, we're primarily focused on the delivery system. And I really love this quote from Dean Fixon and colleagues. They said the use of effective interventions without effective implementation strategies is like a serum without a syringe. The cure is available, but the delivery system is not. So in this situation, like many situations we find ourselves in, we have a cure available. We have an evidence-based practice, an evidence-based intervention, an effective policy. Yet without having a way to actually get that into practice and get it into in this case, arms of people who need it, it's not going to actually have any kind of an effect on population or public health. So that's why we study the delivery system and have such a focus on that. So I'm going to kind of start actually with hybrid approaches. And again, this is a little bit more too of just our 5,000 foot view into where we're going with this. So just as a very, kind of hyperbolic reminder of what the focus of implementation research is and how it differs from effectiveness research, I want to use this little figure that we published a couple of years ago that can be really helpful. So of course, all familiar with effectiveness research, where the focus in effectiveness studies is really the clinical prevention or health promotion intervention. So in Jeff Curran's terminology, this is the thing, the evidence-based thing that we want to implement. In almost all of these studies, the primary outcome, the outcome that gets powered, and the primary interest is going to be intervention effectiveness at the patient level. So we'll be measuring like changes in symptoms, changes in functioning, quality of life, reduction of infections, those kinds of outcomes that are really kind of patient level outcomes. And they're the direct effect of the clinical prevention or health promotion intervention. In all effectiveness research, there are implementation strategies. And they're used to support the delivery system surrounding the adoption and delivery of the intervention. The one thing about effectiveness research is we don't really focus that much on those strategies, even though they are used, and they're of course going to be pretty critical to the overall results of an effectiveness study. So just kind of, again, what are these evidence-based clinical, preventive, and health interventions? They take many forms, and I have here an example using HIV from a really helpful way of thinking about things called the 7 Ps that Hendricks Brown and colleagues published in 2017. So they talk about these evidence-based interventions as being kind of 7 different Ps: pills, programs, practices, principles, products, policies, and procedures. So these are sort of different classes or types of evidence-based interventions that can be implemented, or the focus of implementation research. I present this to contrast it with implementation strategies. I know you've heard quite a bit about these already, so I'm not going to give kind of the basic definitions, but what I want to point out is that in most of our implementation research studies, when we're designing and trying to select implementation strategies, we typically use theory or logic-driven connections to select the strategies. So the connection is between the strategy and the barriers that you'll attempt to overcome with the strategy, or potentially a link between the strategy and things that might facilitate the success of your trial. So factors that you would leverage. I don't know if anyone's talked about the Seifer-Eric matching study, but that was an attempt to really kind of take a look at all the evidence-based implementation strategies from the Eric compilation and map them onto the determinants of Seifer as a way to sort of narrow down the number of possibilities that you could have for each of the implementation strategies. It didn't work super well. One of the reasons is that implementation strategy to barrier relationships are rarely one-to-one. So often one strategy is linked to multiple determinants. You're either going to be leveraging or addressing multiple contextual factors and determinants with one strategy, or it may require more than one strategy to address a single barrier. Also, increasing one implementation outcome could be the result of more than one determinants that require more than one strategies. So the relationships are often really complex. And so to think about it in sort of singular matching one-to-one terms really is just not going to give credence to the complexity of this kind of research. So in actually studying and testing implementation strategies, we have to keep that in mind, that this is really rarely ever a single strategy that's being tested. And to pick the right one requires quite a bit of thought. The ERIC study did help us identify different types of implementation strategies that I think it's helpful for us to just keep in mind. So everything from kind of consumer-focused engagement strategies, or things that target consumers being engaged in healthcare and evidence-based practices, all the way to all the different ways that we support clinicians, the way that we might adapt and tailor interventions and strategies to context, as well as providing things like interactive assistance and developing stakeholder interrelationships. So lots of different kinds of strategies, but you can see in contrast to the 7 Ps, these are all things that are focused on delivery system, whereas the interventions themselves are typically focused directly on achieving health outcomes of the patient. So on the other side of this kind of, again, admittedly hyperbole example is implementation research. So what's helpful about this figure is that it shows really the flip in the foreground background, in the focus now being more squarely on the implementation strategies rather than the clinical, preventive, or health promotion intervention. It's not that it's unimportant anymore, but again, our focus is going to be more on the implementation strategies and the delivery system, rather than an intervention that has shown to be efficacious and effective when delivered with fidelity. At that point, we really want to understand what it takes to actually get the intervention adopted, delivered with fidelity. Because our focus is on the system, you can see here that our implementation impact is going to focus on different metrics. We are going to be thinking about adoption by different providers, by different healthcare systems, by different entities that might deliver the intervention, We're considering the cost of delivery. We're also considering the fidelity with which we can deliver it, the reach of the intervention into the population, as well as the sustainability and actual sustainment of adopted practices. So one thing that kind of bridges these two areas of research, again, two sides of a spectrum that probably is artificial, but really helpful for the heuristic purpose here. We have this special class of hybrid effectiveness implementation approaches. So you can do a singular study that focuses purely on effectiveness. You can also do studies that focus purely on implementation. However, the more commonly the norm now is to focus on both of them at the same time and place those across this type 1, type 2, type 3 approach continuum. So in a type 1 design, we are going to test the thing. That's going to be the intervention. So we're focused again more on the left side of our figure here. We're going to observe or gather information on the implementation strategies and how the implementation happened, typically through a process evaluation or something similar. But again, you can see the focus is really on the clinical intervention on the type 1 side. In the middle, as you'd imagine, we have a co-equal focus. So we're going to test the clinical intervention. We are going to then also test and study the strategies that are needed to actually adopt and deliver that intervention. On the far right in the type 3s, again, we're going to be here on the other end of the spectrum, focusing on strategies first. So testing those strategies and then observing, gathering information on the clinical intervention that's being delivered. One of the reasons I start with this slide in this talk is that I want to be pretty clear that I'm going to focus mostly on research designs that are appropriate for type 2 and type 3 hybrid effectiveness approaches. So designs that are primarily focused on testing implementation strategies. Most type 1 designs are really going to be traditional effectiveness designs that just layer on top a focus on some implementation outcomes. So we really don't change study designs that often in doing type 1 effectiveness implementation approaches. So yeah, keep that in mind that we're really focused on these implementation strategies when we're talking about the research designs here. I do want to mention too that most people are probably familiar with the hybrid design terminology. Jeff Curran, myself, and Maria has been part of these discussions, as well as a host of other folks that think a lot about hybrids, are now starting to use the term approach. And part of this is that the word design often gets confused with the research design, which really is a misnomer and really causes quite a bit of confusion in the literature. So I'm trying in this talk to change my own memory about this and use the word approach, but I might slip up a little bit. So hopefully I'll be able to make this clear as we go through. So in hybrid approaches, as you might imagine from these different types, this is just a little table that can be really helpful about thinking, okay, if I'm doing a hybrid type 1, my primary research aim is going to be the effectiveness of the intervention. My secondary aim is going to be understanding the context for implementation and potentially documenting those implementation strategies. Hybrid type 2, you have primary and co-primary aims. It doesn't matter which order these are in. One is going to focus on the effectiveness of the intervention. The other one is going to either test the impact of implementation strategies or potentially pilot and determine the feasibility of an implementation strategy, likely compared to implementation as usual as a comparator condition. In hybrid type 3s, our primary is going to be determining the impact of the implementation strategy, and our secondary aim would be to assess the clinical outcomes associated with the implementation. So why should we consider hybrid designs? The idea and intent behind these designs is to not have a sequential examination of effectiveness followed by implementation, which then gets followed by larger scale implementation, and then potentially taking things to scale on a really quite large level. So that sequential process is part of the reason that we have that 17-year gap in discovery to real world practice and use. We also want to kind of point out too that hybrid designs or hybrid approaches allow you to sort of not wait for perfect intervention effectiveness data before you start thinking about implementation, or before you start actually potentially in a type 2 would start to test implementation strategies. And this can be important because the traditional translational pipeline basically assumes some sort of kind of pure perfect study to then move on to the next step. And hybrids are a way to reduce those steps and potentially to speed research. It's also a potential way to backfill effectiveness data. while we are testing and evaluating implementation strategies. So in certain situations, and actually the COVID vaccine is probably a great recent example, unfortunately, where that went from efficacy testing for the most part, does this actually work and have few side effects, to wide scale implementation. So there really wasn't effectiveness data about how is this going to work in the real world? How are people going to react? Is there going to be interactions? All these sorts of things that we typically try to understand in effectiveness studies. Because of the public health emergency that we were facing, the vaccines got rolled out before sort of effectiveness data had been formally tested in kind of the more traditional way. So in that case, we were able to backfill the effectiveness data by tracking new infections and looking at case counts while we were actually setting the implementation and how we could actually get it out to the population. Another reason is kind of considering how you have to basically have both sides of the coin, both the implementation and effectiveness outcomes, if you're going to understand how the intervention outcomes are related to the implementation outcomes. So of course, we know that low adoption, low fidelity, low reach of any intervention is going to have a detrimental impact on its overall population impact. And really to understand how that happens, you have to have data on both sides of these of the continuum. So now I'd like to get into actual research designs. And again, this is really a focus on predominantly experimental and quasi-experimental designs meant to test the impact of implementation strategies. So yeah, hopefully with these examples and the actual talk and a couple of examples that I've included, that'll be clear about how these might differ from other study designs. So anyone who's been in this field for more than a minute probably appreciates a lot of these challenges of designing implementation trials, but I think it's still helpful to kind of talk about and level set kind of what we're dealing with and why some of these designs may be the way that they are given the constraints and the intent of implementation research. So one of the kind of characteristics is that in moving towards implementation, you are starting to more focus on external validity of the findings, or at least kind of have a co-equal focus on external validity, but also the internal validity of demonstrating that the strategy actually is the reason that you see the changes that you do. So we still often need an internally valid study, but the way that we design studies, the way that we interpret data, the implementation strategies we may test all should have an eye towards external validity and sustainability at the same time. One of the principles too of kind of working with delivery systems is we really want to design studies that minimize disruptions to and burden on those delivery systems. For obvious reasons, that's going to make your actual study harder if you're going to be burdening the system and making them change in dramatic ways. But from the other perspective too, that's unlikely that that kind of an approach, even if shown to be effective, could be replicated and sustained across lots of systems. Because we can't really expect systems to change drastically. They, in certain situations, have, but it's not the norm. One of the ways to help minimize disruptions and burden is to design your study with your community partners. So design, and community partners is intentionally broad. This is not just talking to the direct delivery system that you'll focus on. But when you design the study with community partners, it has to do with, okay, the recruitment, the eligibility potentially, the processes to which actually getting patients or participants into your study. It could also be whether or not randomization is possible. I'll talk about that here in a second as well, at the system level. So one of the challenges, but also characteristics of implementation designs is that randomization typically occurs at what I'm going to call higher levels of the service delivery system. So all of us are likely familiar with clinical trial randomization, which is predominantly at the patient level, or even cluster randomized trials are really still focused on patients, but they often recognize that delivery occurs within clusters, so the cluster can be randomized. Because we are looking at these higher levels for randomization, it often leaves us with a small number of units to actually randomize, because studies get both complex but also costly. As you start to involve lots and lots of clinics, lots and lots of health delivery systems, even potentially multiple countries. There are examples of WHO studies and World Bank studies that have randomized countries to different interventions or different implementation approaches. So you can see how the actual leveling can be quite large, but also it limits the number of units that you can include. And of course, because of this too, we always have nesting within multiple levels of the system, as well as the resulting interactions between them, which is more of kind of an analytic challenge, but it also can be one of the challenges for randomization and the design of the study itself, because taking into account and consideration those multiple levels in the nesting structure and the interclass correlation coefficients is really related to power. And so, thinking through which is the appropriate level of analysis, the appropriate level of randomization is often really critical. In most experimental implementation designs, the implementation strategy or strategies that are being tested are the things that are manipulated by somebody, and thus serve as the independent variable that differentiates study conditions or study arms. So in choosing a design, there's a few things to keep in mind or ask yourself as you're kind of going through this process. So of course, the main thing is to really have a design type that can answer your implementation research questions. And I kind of mentioned earlier that, well, what if your implementation question is really more of an implementation preparation aim? So you need to figure out the feasibility of actually using an implementation strategy, or potentially you need to adapt an evidence-based intervention to better fit with a particular context. Neither of those research questions, while very common, actually require an experimental design. So there's other kinds of designs that would be better suited for that. I do have a talk where I go into some detail about those alternative kinds of designs for those research questions. But really here, again, we're talking about actual formal testing of implementation strategies. So one thing to also consider is what level in the system is your primary outcome being measured. And in ideal situations, you would have the primary implementation outcome aligned with the level of the strategy that is targeting that outcome. And so a really easy example of this is, clinician or provider focused strategies. If that's going to be the main implementation strategy that you're using, your primary outcome should likely be something at the clinician or provider level, most likely adoption and then fidelity of delivery for those who do adopt. In other situations where maybe you're using a clinic level implementation strategy targeting multiple workflows and other complex kinds of challenges within a larger system or a larger unit, you may likely then focus on adoption at the higher level, like a unit or a team level, or you may be focusing on the reach of the intervention to the population that system serves as a way to understand how the system actually functioned and changed. One question always is too, do you have sufficient units to answer your implementation research questions? So it's a pretty common pitfall to potentially propose a study that is underpowered or that just has too few units of similar homogeneity to actually be able to reasonably answer a test of an implementation strategy. So this is where having multiple units and getting beyond that kind of small n challenge is really critical and important, but can be a little bit hard depending on the context of the study. Another question obviously is, can you randomize? Most of the study designs that I'll talk about today, I'm going to talk about them as randomized trial designs. However, they can be, there are versions of each of these that are non-randomized or that potentially have some kind of a restricted randomization. So, there are ways that you can do these kinds of designs without randomization, but you then introduce a lot of the confounders and potential alternative explanations that, randomization tends to take care of. So there are other challenges for non-randomized design. So I'm mostly going to talk about randomized. Another question is whether or not implementation as usual is an acceptable comparison to your community and clinical partners. And this really comes into whether or not you are going to randomize, say, different clinics to getting an active implementation strategy, or being in the control condition where you say, here's an evidence-based intervention, go ahead and implement as usual. We're going to evaluate and track your implementation. And that approach isn't always acceptable to different systems, might also not be ethical or moral, depending on what you're actually trying to implement. So I'm going to try to talk about a few designs as well, where every unit within a study is going to get exposed to the implementation and either not serve as implementation as usual or not serve in that condition very long. So there are different types of design. So there's kind of different classes. So I'm just going to give a broad overview and then give some detail on each of these. So kind of at the beginning, and this is laid out sort of in a continuum of sort of less rigorous, less likely to be experimental, all the way to fully powered experimental designs and trials of implementation strategies. So I sort of mentioned these implementation preparation studies. These typically use formative or developmental research designs. These are things like where your research aim is really trying to help understand context, help you select, tailor, or adapt strategies for later testing, but typically doesn't actually involve a pilot or even a form or a more formal, RCT or design that would test the implementation strategy itself. There are many non-experimental and observational study designs. I'm not going to talk about those today since those do have their own kind of set of challenges. A good example of non-experimental and observational study designs are when policies get rolled out. It's often really difficult to have any kind of a randomization within that because everyone's expected to adopt a policy as soon as it gets released in most situations. And so we use study designs like interrupted time series and regression discontinuity and other kinds of designs that are really looking at more naturalistic flows with likely less control by the researcher about when that happens and to whom. We also have a class of within site designs. Within site designs are generally relatively simple. They typically do not involve randomization. And the comparison within a within site design is often compared to pre-implementation. So what the site was doing or able to achieve prior to the introduction of new implementation strategies, or you compare it to no implementation. And usually the no implementation is not ideal because that means that you don't have a baseline comparison. And so you're doing a post design. So there's challenges with that. The two types of trial designs or types of designs that are more that lend themselves to experimental tests of implementation strategies are between site designs and then a class called within and between site designs. In both situations, you're kind of banking and working off of an assumption that replication and aggregation across units is going to increase power, increase the generalizability of the findings. Randomization can reduce bias in these kinds of designs, kind of as I already mentioned. So when possible, randomization is certainly preferred. And these typically involve a comparison of implementation strategies, again, with implementation as usual being the most common comparison, but I'll talk about some designs that have active implementation strategies in multiple arms. We then have within and between site designs, and everyone's probably relatively familiar or at least heard of stepped wedge designs. Stepped wedge designs are a special, or a very unique design within the broader class of rollout designs, which really are, you get assigned to the time at which you start the implementation, rather than to different study conditions or units, conditions. The units themselves actually get randomized to when they begin, and I have an example of this to show. So kind of going back into a deeper dive on the ones that are potentially more experimental and that we can apply experimental design principles to. In the within site designs, these are typically going to be pretty small ends. You're going to either do a post design when implementation was not occurring, when a service was not available, and therefore outcomes were not relevant in the pre-period. And so in that situation, you're usually introducing an evidence-based intervention and an implementation strategy simultaneously. And that makes it so that you can do a post design over a certain period of time, but not anything stronger than that. If it's a practice or an outcome that's already been implemented or tracked, you could potentially do a pre-post design. So examine implementation outcome change and potentially change in the effectiveness of interventions over time compared to pre-implementation or pre-exposure to the strategy levels. We often also use interrupted time series designs. These are rarely randomized, but they can be. There are examples and methods for actually doing randomized, multiple baseline designs that use an ITS approach. And one thing that's important to remember about within site designs is that a single site or a small number of sites can demonstrate the feasibility and initial impact of an implementation strategy, but you really do need more sites for a full evaluation, largely due to power and internal validity concerns. In within site designs, any of the hybrid approaches can be used, but most commonly you'll see either a type 1 or a type 3, as the designs themselves, these designs lend themselves to having a primary focus on either the implementation outcome or the effectiveness outcome. And I would say it's probably still more common to see a type 1 in this situation. So for both between site and the within and between site designs, they share a few commonalities. Again, the most common comparator to the novel implementation strategy, or the implementation strategy that's going to be introduced and is really the main focus of the study, is going to be against routine practice. There are examples of what we call comparative implementation, where two or more novel implementation strategies or implementation strategy packages are tested against one another for delivery of the same clinical or preventive intervention. So one of the 7 Ps. And I have an example of this as well to kind of get into a little bit more depth about how this might be tested. You also have 2 and 3 arm cluster randomized trials. These are relatively similar to other kind of cluster randomized trial designs that you might use for a clinical trial. However, again, these are randomizing at higher levels and larger units above the patient level. So they tend to have their own challenges methodologically because of that. We then obviously have the rollout and step wedge designs, which I do have an example of as well. And then there's a class of factorial designs and SMART trials. SMART is a very specific example of a factorial design. And these can be randomized or non-randomized, or have combinations of both randomization and non-randomization. SMART designs, by definition, have sequential multiple assignment randomized trials, but in other factorials, they have a bit more flexibility in what you can do with the different conditions and different factors. For these larger between site and within and between site designs, any of the hybrid approaches, again, can be used. If you're kind of back in the type 1 stage, you may be using one of these trial designs to actually randomize at the patient level. That would be really conducive only to a type 1. You might be able to call it a type 2. But if randomization is occurring at the clinician, clinic, community-based organization, hospital, or county level, or something along those lines, you're almost assuredly going to be a type 2 or a type 3, or at least they'd lend themselves better to a type 2 or type 3 design. And of course, there are exceptions to this guidance because hybrid approaches are not dictated by the trial or study design, but certain trial or study designs do lend themselves better to certain types or different types of hybrids. So I will give a couple of interesting design examples that combine cluster and patient level randomization. I actually don't have the new impact, Northwestern University impact study, because it's very complicated and difficult to explain in a short period, but I do have the Raising Healthy Children study that I can show you. I also want to show you first, actually, the collaborative care model trial that I am PI of at Northwestern Medicine. We are testing in this trial the effectiveness and implementation of the collaborative care model for depression and anxiety, and comparing it to services as usual in primary care. So we used a matched pair randomized rollout trial design that had a type 2 effectiveness implementation approach. So we have co-primary aims and foci. So the implementation strategies that we're using, it is of course a cluster or a bundle of strategies. We are using things like in-person training, ongoing booster training and reminders to clinicians. We've done EHR modifications for ease of referral and also to help us track program status. The program status tracker is really important because we're also using an audit and feedback implementation strategy. We also have introduced some financial and billing solutions to make this cost effective and hope maybe even cost neutral for the system at least. And we published some of that data in an article last year in Medical Care that Courtney Wolk from Penn was the lead author of. We also leveraged a recently passed Illinois law. It was recent to the time at which this trial started, about 2 years ago. It's now been in place for about that long. But in Illinois, there is a state law that actually says all insurance carriers have to cover collaborative care specifically for depression and anxiety. So it isn't, of course, equal across all providers or all insurance providers, but there is a law in place that says reimbursement should be part of their coverage. In our analysis plan, this really reflects our 2 co-primary aims. Our effectiveness is that collaborative care model will have effects on reducing depression and anxiety symptoms, compared to non-enrolled participants that occurred simultaneously, as well as participants or patients that were in the pre-condition before the study, before each of the different clinics began the rollout. And I'll show that in a second. For implementation, we're primarily focused on the reach of the intervention into the eligible population, as well as the adoption by different clinicians. This was a top-down sort of implementation where the healthcare system said every primary care practice has to adopt. And so there's going to be zero variance in terms of adoption. But at the clinician level within those clinics, there isn't a mandate. And so there will be variable adoption rates at the clinician level. And we're also closely examining health equity in these outcomes, or at least evidence of any potential disparities concerning the representativeness and the different groups that are actually being reached by this intervention. We're also examining sustainability that we can compare pre and within and across clinics. We're using mixed methods analysis as well to really understand the primary care provider and support staff's view of the acceptability, appropriateness, and feasibility of the collaborative care model, and with our implementation strategy that we're testing. And the full protocol was published in Contemporary Clinical Trials Communications a few months ago. So here is just a little diagram of the rollout design that we have here. This one involved 11 clinics, which is why we used a matched pair randomization approach, which increases power. So the matched pair approach basically randomized them into pairs, and those pairs are non-sequential. So for example, clinic 1 and clinic 3 might be a pair, clinic 2 and clinic 4 are a pair, 5 and 7, 6 and 8, etc. It got a little funny because we have a third, an extra clinic. So one of the conditions actually has 3 clinics that are paired, quote unquote. But that helps actually try to control for any confounders that might be related to the differences in the clinics as you roll out. In this particular design, we have only a 6-month pre-period where we are having them track carefully their different implementation outcomes for depression management before collaborative care begins here at the step. And then we're following each of the different practices for the same exact amount of time. So this is not a stepped wedge design because it does not have wedges, right? It has steps, but we actually have not complete wedges on both sides of our data collection. So other folks have called this a staircase design. There's multiple names for what this is, but really it falls in the broader class of a randomized rollout design. The results of this are pending. We are almost done with data collection. So this was really just the design piece. And part of the reason that we chose this design was for 2 reasons. So this design allowed us to actually have sufficient power despite only having 11 clinical units. We also had a mandate that every clinical unit had to adopt within a 2.5 year period. And so that meant that randomization was only possible at the timing level. It was not possible to randomize to an implementation as usual condition. We could have potentially randomized to 2 different implementation strategies, but we would likely be underpowered given that we only have 11 clinics. So, even doing a balanced randomization of 6 and 5 to 2 different strategies, we would likely be underpowered to detect any differences between those. So really the rollout design for all 11 clinics getting the implementation staggered over time was one of the best ways to do that. So a slightly more unique example here is what's called the Raising Healthy Children study. The study protocol was published in 2018 in Implementation Science. This is a trial that was funded by the Centers for Disease Control and Prevention, Childhood Obesity Research Demonstration Project Award that I received with my colleague, Katie Burkle. So this is a cluster non-randomized design with an embedded patient-level randomized control trial. And we were successful in being able to argue that this is a hybrid type 2. It's probably more like a hybrid type 1.75, given that this is a spectrum, but you're kind of forced to pick one of the 3 types typically and make a justification for that. So it is a type 2. So in this design, we had non-randomization of clinics to implementation strategy conditions. The reason we had non-randomization is that one of our primary sites that we've been working with actually did not have capacity or ability to do one of the implementation strategies. And so they were automatically going to be assigned to the strategy that they actually could do. And then we recruited additional sites that had the capacity to do the other implementation strategy specifically. So that's the non-randomized component to the different strategy conditions. So those two different strategies were kind of the most two common models for integrating behavioral health and behavior change interventions into primary care. And that is the most common model of referring to service providers outside the clinic. This is very common for like specialty care, mostly specialty medical care, but also is very common in the United States anyway for referring to behavioral health and health promotion interventions. Those typically occur outside of primary care. There also is a model in federally qualified health centers that we were able to involve where they do integrated or co-located delivery within the clinic itself, or at least delivered by the clinic employed staff, folks that tend to have a warm handoff. Whether or not they provide services in the clinic, they're allowed to do things like home visiting as well. But again, we had one of our primary clinical sites that was not able to do the integrated model. So that's why they were assigned here, and we recruited other clinics to be able to fill out our comparison. Within each of these conditions, families that were deemed eligible for inclusion were randomized to services as usual or to our intervention. So that's the embedded patient level RCT that was fully powered for our intervention effects. And then we had sufficient number of families in each of the conditions to be able to test for implementation outcome differences. So in this kind of design, which again is a comparative implementation design, you have two different strategies for the same intervention, which in this case is called the Family Checkup for Health, or FCU for Health. And you can tell because these are pretty significant, not significant, but they're pretty different implementation strategies. The delivery system for Family Checkup for Health is different, but they are both shades of green. So they are not completely different. They are just slightly different from one another because of those implementation strategies that basically are part of that cluster. So in the comparison of implementation strategies, this is important for how you design a comparative trial. We had a number of implementation strategies that were shared across both conditions, which include how we identified kids through the EMR, how we actually recruited them using their PCPs, as well as case finding in the EHR. The training, consultation, fidelity monitoring, and certification processes were held equivalent across these two arms, so that really we were isolating the effect of the implementation strategy, not the intervention itself. The program components and content were held the same so that families didn't experience anything different across the different arms. And then randomization and services as usual happened within organization rather than at the organizational level because of the limited number of units that we had. In the integrated co-located delivery model, I'll just show quickly the differences in comparison. So these are the same analogous kind of function or strategy that needed to function in a certain way. And you can see in the co-located model, we trained existing behavioral health staff. In the referral-based model, we actually hired behavioral health staff to deliver the intervention. They were study employees, not health system employees. So those are some of the differences that would help us explain why we found differences in the arms. Normally at this point, I would take a little poll and I would ask which one of these two implementation strategies do you think was better? I will spoil the fun and just say that after about 6 months, we realized that the integrated co-located care model was going to fail. And we were able to adjust and change the study design to become a fully referral-based approach, where the federally qualified health centers that had been involved originally in the co-located integrated care model delivery were joined by a number of other FQHCs who had been interested in participating, but hadn't heard of the study at the time or kind of came onto our advisory board later. The Children's Hospital continued, that was the referral-based arm. We also received referrals from a military health clinic and private pediatric practice. So we were able to really expand our referral-based network and really hone in on better what the feasibility, acceptability, and costs associated with a referral-based model were. Unfortunately, not really in comparison to the integrated co-located care model, because as I mentioned, we found that it really was going to fail. And we were lucky to be able to change the study design kind of midstream. We did find ultimately that in comparison to services as usual, the Family Checkup for Health was effective at changing multiple outcomes, both health behaviors in service of reducing obesity, but also reductions of conduct and internalizing problems that are often associated with obesity and other issues. We also found that the intervention was delivered with very high fidelity, actually very close to the efficacy trials that preceded it. So I'm going to jump in now, actually, get away a little bit from research design and talk a little bit more about the implementation research logic model, which is really a way to help design and execute studies. I don't have a lot of time to go into it, so this is going to be kind of a crash course into this. But like I said before, I hope this is something that kind of gets folks interested, and you might look at some of the additional materials that we have for more information. So a few foundations of the IRLM. This tool was really created to help us integrate the necessary conceptual elements of implementation research. And as you probably already heard over the last couple of days, there are lots of theories, models, and frameworks, and almost every large implementation study is going to involve multiple, kind of by design and by necessity, because different models and frameworks do different things for the study. We also wanted to help improve the specification of implementation research phenomenon and really try to get us to understand for whom, under what conditions, and potentially why implementation strategies work or don't. And we based our implementation research logic model on a generalized theory of implementation research, which I'm going to just jump right into. Actually, no, I'll go ahead and do a generalized theory. So the generalized theory, as you probably kind of gathered from other presentations, is that we select implementation strategies to address specific barriers or contextual determinants. They're also linked to the elements or core components of the intervention itself. So certain strategies are needed for certain intervention components to address certain barriers. If those are going to work and affect the outcomes that we are interested in, those strategies are going to work through a specific mechanism of action. So those are the four things that we tend to really specify within an implementation research logic model. We often get the question of why should I use the IRLM? Isn't it just some other model? There's one thing to choose from. So we often get the question, can't I just use CIFAR or REAIM? And I hope that it's been communicated that CIFAR is for a very specific purpose. It doesn't do everything. Similarly with REAIM, despite its hundreds of thousands of citations, I'm sure at this point, it is for evaluation, right? It does one thing, serves that purpose very well, but each of these different theories, models, and frameworks really have a singular purpose. So the IRLM helps actually pull together multiple theories, models, and frameworks into one logic-based model to help us really kind of, again, put the pieces together. As you probably have already heard, it is really common to use multiple models and frameworks, but it is not easy to combine those all the time. The IRLM helps us combine them in a manner that facilitates specification in the relationship between the different elements, and then also includes implementation strategies. And the IRLM is really good at giving the reader a snapshot of the many elements of an implementation project, as well as their known or hypothesized relationships that are either going to be tested or form the basis of why implementation strategies were selected and why you think they're going to actually be effective. You will still most likely need another model or framework depending on the nature of the project. Really common to use a process model or like a stage-based model like the EPIS framework, for example, or others, because the logic model doesn't do everything, even though it is meant to be kind of a meta model that pulls things together. I'm mostly going to talk about the use of this for planning and working with community partners to fill out the logic model, both the strategies, but also the determinants. And you often begin with the known parameters of a study when you're kind of starting to complete it. So you might know what outcomes you're trying to get to. You might know the context you're working in. And then from there, you can fill in the other pieces of the logic model. We also think it can be used to actually help you execute a study. So serving essentially as a protocol for how to do the implementation once a project is funded and starts. And it could also form the basis for tracking what actually occurs, what's altered, how things potentially deviate during a study. And then of course you could use it to actually report what happened. Showing which of the barriers were most prominent, which of the facilitators actually helped the effort, and then the implementation strategies that ultimately were actually used or shown to be effective, depending on how you want to use it. So the standard implementation research logic model really fits the generalized theory. It really shows the connection between the determinants, the implementation strategies that you select, the mechanisms through which they work, and the outcomes they should achieve. This was considered kind of the original IRLM, but we've actually moved more towards this model, where folks often find it really helpful to include the clinical intervention, because again, there is a mechanism associated with why did you choose the intervention that you did based on the context you're working in. And then, as I mentioned before, strategies are helping us to address implementation barriers, but often for specific components within a clinical intervention, especially one that's like a multi-component intervention or complex behavioral intervention or something that just has more than one single thing that needs to be implemented. You'll notice too, if you're familiar with the Proctor et al. 2011 implementation outcomes taxonomy, that this is their model flipped on its side. So this is really showing that the proximal impact of implementation strategies through their mechanisms is on implementation outcomes, and that those are really kind of necessary and precede outcomes that we would see at the clinical and patient level or potentially at the service level as well. This little kind of gray arrow is intended to show that there is a direct effect between the clinical intervention and the patient outcomes. However, full program and implementation effects occur through this longer pathway through strategies and outcomes. I also want to show kind of a new thing that I've been working on, which is there's lots of variations of the IRLM. This one was done for showing multi-level interventions, which are really common. So multi-level interventions are defined as interventions at 2 or more levels of individuals, clinical teams, institutions, et cetera. So even in this definition, you're saying as an implementation scientist, okay, so the intervention at the individual level is our clinical or health intervention. The interventions that occur at the clinical team or institution level, those are implementation strategies. So this is really just kind of flipping the nomenclature and helping to put this into implementation terms and also within the IRLM. So in this case, I'm going to give just a quick example using the Kaiser blood pressure control bundle. So this bundle is the thing that was tested as an evidence-based strategy, evidence-based intervention shown to be effective. When you actually break down the Kaiser bundle though, you see that 4 of the components, there are 5 components for the Kaiser bundle, 4 of them are actually implementation strategies. None of these things are targeting or directly going to impact clinical or patient outcomes. They are all to help the system actually do the Kaiser bundle and control blood pressure. The thing that's actually going to be the clinical or preventive intervention is the guidelines that you select, which is one of the other components, is to distribute an evidence-based blood pressure control guideline. So those things are going to impact the actual clinical outcomes. And then also the use of single pill combination therapy for blood pressure control is one of the parts of the Kaiser bundle. These are the only 2 pieces, despite this being tested as a multi-level package or bundle, that are clinical and health interventions. So in this case, what we're doing is basically demonstrating using the logic model itself that these implementation strategies, while having to be coupled and tested as a bundle, are strategies, right? We're differentiating them from the clinical intervention. We're showing that they're part of the implementation strategies, despite being part of this larger bundle. And then in this case, you're going to have additional implementation strategies that are needed to implement all of these things. So this kind of shows also to the hierarchical or multi-level nature of implementation strategies. Some strategies are needed to implement other strategies. This is not the easiest example, but it is a nice way of showing the complexity, but also the way to make it somewhat simple. I'm going to skip through this. I'm just going to show that there is a really nice paper that we published actually just a couple of months ago using a stakeholder-driven method for selecting implementation strategies. And this was a case example from pediatric guideline clinical practice. So this is actually published in the paper, a mostly completed implementation research logic model. So this kind of shows you the complexity at which you can get into and the detail that can be provided with an IRLM. And this actually only really took us to identification of barriers and facilitators, and then the selection of implementation strategies to overcome those barriers in working with our clinical partners. And we didn't even get into, we hypothesized mechanisms, we showed which implementation outcomes and clinical outcomes we were hoping to achieve. But really the study itself was focused on this part of the implementation research logic model and led to a grant application to test the strategies here that were identified. There are a bunch of resources. So there is a website for the IRLM that is hosted by the Center for Prevention Implementation Methodology at Northwestern. A lot of helpful handouts, as well as templates of each of the models that you've seen today for the IRLM, as well as some links to some videos that I've done some longer presentations on it. That is my time, and I would love to take some questions and see what people's thoughts are about these implementation designs.